Right, we've heard a lot already today about JCVI, which is the Joint Committee on Vaccination and Immunisation. And it's an independent departmental expert committee and a statutory body, so that's its official designation. And just to give you a little bit of background about where this committee comes from, because it has actually been advising the Department of Health for a very long time about all of the policy that you then go and deliver through the vaccine programme. In fact, it started in 1963 when it was the Advisory Board on polio immunisation. And I don't think there's anyone in this audience who will remember the polio epidemics that happened in the 1950s that led to the development of the polio vaccines. And 1963 was when this advisory board was set up to try and make decisions on use of polio vaccine. And it became a standing advisory committee, which is another official designation from the government under the England and Wales NHS Act in 1977. And then was established again under the NHS in 1981. So that's the designation. So it's a formal body which reports to the Department of Health. And its purpose is to advise the Secretary of State on the provision of vaccine and immunisation services for the prevention of illness. And importantly, it has no budget to do this. So it's essentially the Department of Health pays some travel expenses for the people who are on the committee, but everyone has to be there on their own time. And this gives a longer summary of what the committee does. And I'm going to go into some of the details of this as I talk over the next few minutes. So since the 1st of April, the JCVI has had a slightly different role under the NHS Constitution. So it's gone from a position where it just gave some advice to the Department of Health to actually having a situation where the Secretary of State should ensure, if it's practical, that the recommendations that come from JCVI are then put into policy. So that's a difference from where things were before. So under the Constitution, JCVI's decisions can or should then go into policy afterwards. So it gives quite a lot of authority to that committee. But there are a few provisos. First of all, that JCVI can't make decisions about things not related to vaccination. So they have to relate to new provision of vaccines under the national programme, or it can be changes to the programme. So new provisions might be something like rotavirus vaccine, or changes to the programme might be things like adjusting schedules for Men C. So both of those things are the duty of the committee to have a look at and give advice on. The decisions have to be made by the main committee and not by a subcommittee. And interestingly, they also can only make these sort of power decisions if the Secretary of State has asked for this issue to be looked at and for a recommendation on it. So, for example, on rotavirus vaccine or HPV vaccine, the Secretary of State would have to ask the committee to look into that as a vaccine issue and then provide advice to the Department of Health on whether such a vaccine should be used. And perhaps the most important of all of these, in terms of the deliberations of the committee and how it's functioned over most of the last decade anyway, is this last one, which is cost effectiveness. And so the first thing is you have to look at the vaccines if the Secretary of State asks, but you also can only recommend that they're used by the Department of Health if they are cost effective, and I'll touch a little bit on that a little bit later on. And the reason why that's so important is it's not the same as all other countries. Many countries use cost effectiveness, but this is a final arbiter in this country for decisions that are made. And that's partly because we have the NHS, so we have a finite budget within the NHS. And you have to be pretty sure if you're going to introduce some new treatment into the NHS that that's not stealing money from some other bit of the budget. So in other words, it has to be cost effective. And then there's a couple of other issues. Recommendations shouldn't relate to travel vaccination. And the duty on the Secretary of State ceases if the committee withdraws its recommendation. So the committee is made up of people who have expertise in these large number of areas, and I think that's important to make sure that the decisions that are being made are made not just those of us in the front line dealing with the disease, but people with expertise in all of the areas that you would expect to make such important decisions for the NHS. And there are also lay members on the committee as well who provide a public perspective. So this is the list of people who are on the committee at the moment. I'm sure you'll know some of the names there. And these individuals, most of them are from the UK, but the Department of Health can appoint people from outside of the UK to the committee where they feel that expertise can be found. So that's the committee. In some ways it would seem a relatively small room with a few people chatting if it was just this committee, but actually there are an enormous number of observers who are in the room when the committee sits. And many of these areas don't bring just one person, they bring several people. And so the room has, I don't know, Caroline, 50 people in it, maybe more than that, maybe 70 people in the room. But only the committee is allowed to vote on decisions, and most of the discussion focuses on that. But I think this is actually great because many of these observers who are there are able to offer perspectives and expertise from other walks of life. The development of the advice that and the recommendations that JCVI make are based on the review of the best evidence there is, as I'm sure you'd expect. And that comes from epidemiology, from clinical trials, from immunology, safety of vaccines. There's also attitudinal research, often that's done around vaccination. You heard that mentioned this morning by Helen. And there are also calls for evidence which are put out to get additional information either from industry or from other stakeholders in vaccination. And sometimes the information is very complex, and there's a pre-stage which is suggested by JCVI to have a subcommittee which will sit often with a lot of very focused expertise on the particular vaccine or the disease, who will then go through the enormous amount of data that there are to look at in order to then provide a synthesis of that information for the main committee to come to a decision. So I mentioned cost effectiveness, and this is, I think, a very important area, as I mentioned, for the NHS. And that decision of whether a vaccine is cost effective or not is complicated. It's not quite the same as what NICE does, where NICE decides whether, with the price that there is for a new drug, whether that would be cost effective for the NHS. The way that JCVI operates is it finds what the cost effective price would be. So that's a slightly different way around. So if you take the list price for many vaccines, they're much higher than the cost-effective price that the Department of Health would use for negotiations. And the development of cost-effectiveness is a complex beast, and it requires the weighing up, on the one hand, of the costs of the vaccine and its delivery, and on the other hand, the savings to the NHS if you prevented that disease. So if you prevent cervical cancer and you don't have to manage those individuals who have cancer with surgery or chemotherapy and so on, then you're making a big saving to the NHS, and you can balance that against the cost of the vaccine and find a price which, based on a particular threshold that's agreed, which is called the cost per quality adjusted life year, then there is a price which can be calculated from what we understand about those costs and benefits for the NHS. And importantly, in the models that are used in the UK for all health interventions, that balance only involves costs to the NHS. So if a child ends up with a disease which causes them problems in their education in the future, those costs for the education system are not included. And it's a focus just on the NHS budget in calculating cost effectiveness. The methodology that's used is, though, the same methodology that NICE uses for assessment of other health technologies. It's particular guidance from at NICE that's used in calculating cost effectiveness, adapted to be appropriate for vaccines. And that summarises those. So JCVI looks at new vaccines and all new vaccines in the future that will come to licensure that could be recommended for the UK population. We'll go through that process. Also looks at changes to the current programme, but also might look at either emerging issues that we haven't guessed yet, but might come along, and emergencies. And examples of those are things like the emergence or re-emergence of pertussis and having to rethink about the approach for pertussis immunisation through the vaccine in pregnancy, or in 2009 JCVI were involved in the decisions about pandemic flu. So what the JCVI does, and this is my last slide, is assesses the best available evidence, that tries to gather all the evidence that there is to make an assessment about a new vaccine and about the immunisation programme, and has great expertise on the committee and from the other people who provide advice to the committee on the epidemiology of diseases and how well vaccines work. And then with that information is able to advise the Department of Health on the current programme and make recommendations about the use of new vaccines. And also the committee looks to the future of the programme to protect our population through vaccination through a horizon scanning process, which is actually underway at the moment, to look at what vaccines there might be that we should be considering to improve our population health. So that's JCVI for you.